Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. It's quite a long video, it's a very complex case. It's of a patient who has to attend twice a year, and we're just starting off in their left end. Their main issue is that they have a tremendous amount of hair loose in the ear. So most of us have these hairs called cilia, and they're located on the outer third of the ear canal, or externally, so on the tragal cartilage. So the tragal cartilage is the triangular piece of cartilage on the outside part of your ear, in front of the entrance of the ear. However, this patient, they trim their ear hairs on a regular basis, and what happens is that these hairs fly into the ear, and they're all loose, most of these. So the ones you just saw there at the entrance, these here, they're the natural hairs. Now, they're not actually causing the occlusion. They're still attached to the ear canal. The follicles are embedded deep within the ear canal itself. But the ones that we're removing, these are all hairs that have been trimmed, and they fly into the ear. Now, we have tried and got the patient to insert some cotton wool at the entrance of the ear when they're trimming the hairs, but admittedly they advise that they don't regularly do that, and it kind of, I wouldn't say the hairs are the sole cause of their problem. So entangled within the hairs is a lot of soft wax, but you can see I'm just using the forceps, so I'm just pulling these hairs out, and as I'm pulling the hairs out, the wax is coming out. Now, this was the easier ear at the two. The right ear, if you do stay tuned and watch the right ear, is a really complex, because the right ear is also infected. So not only did they have the hairs, and it was also discharge in the ear, as otitis externa. So we've already cleared the obstruction for the patient. You could see the eardrum just a moment ago, but there was a bit of wax at the roof of the ear canal, just removing that as well. And just going back to the suction probe here. And what I'm going to do, I'm going to go back in the ear in a moment and with the forceps and just try and remove as many of these hairs as possible. And as I said, these are all loose hairs. They're not attached to the canal, so we're not plucking these, we're just removing them. And you can see it's a bit stuck at the roof of the ear canal. Now, the patient also does get a lot of water in the ear, and that's what's caused the infection in their right ear. So there's the eardrum, so it is visible, the hearing's back to normal. So just try to take a close-up of the flock of hairs. And they do have a bit of otitis externa in this ear, so it's a bit of eczema in the ear, but the right one is a lot worse. So they've got a slightly bendy ear. It's nearly impossible to get all these hairs out singly. It would be there all day, and some of them, particularly on the right ear, because the ear was very wet on that side, they were stuck to the drum. But already you can see the pathway is a lot clearer. Now we're just going to be careful here. This is just near the front anterior canal wall. We don't want that jaw touching the canal wall, because if it grazes it, it will be uncomfortable for the patient. So I think there's just one or two there left. I'm just trying to get some of these more external ones out. So we go, just gonna be careful, we don't want to be touching the eardrum. I just felt at that point, we just leave the rest of those. Patient's fine. Now, it's a bit of dry skin at the top, so I went in with a fine end trying to peel that away. I did loosen it, but I had to stop because it began to clarinet and it was really noisy, and so we don't want to make the procedure uncomfortable for the patient or possibly cause a temporary or even permanent threshold shift. So clarinetting is when the skin, you can see this is skin, and when you're performing suction, which is, we don't really want to be using the forceps here because we're too close, and the top jaw will be touching the roof of the ear canal because it's right up against the canal. The dead skin can flap, and that flapping, when it's been vacuumed, can emit a very loud high frequency squeal, which can be very noisy, not only for the patient but also for myself before performing the procedure. So it began to clarinet, and we just at that stage decided just to stop. Because again, the main purpose of earwax removal was to ensure the patient can hear better. Now, this patient is going to have a regular build-up, not only because of the hairs, but they have got this otitis externa, and eczema of the ear, and that's a long-standing condition for the patient because it's really strongly adhered here. I'm just trying to tug it left to right, and I think it's started to clarinet in a moment. So although there's a bit of skin left at the roof of the ear canal, as we're vacuuming, it is suctioning some of these loose hairs out as well. I think that's the point we kind of stopped. Now this is the patient's right ear. You can see it's really gunky, it's inflamed. It's very difficult even getting the instrument in because it was so swollen at the entrance. And this reflection is all the discharge. So when you've got an infection like this, it does reflect the light back. So the light of the earwax or the dead skin or the infection, you get a lot of reflection. So I'm just trying to clear the entrance here. You can see we're getting less reflection already, and we can see this is a bit of a mess in here. You've got all these loose hairs, but instead of wax, it's all this discharge, all this infection. And it does make it really, really difficult to remove because this discharge is what we call outer ear. It's very thick, and it was layered on the canal wall and on the eardrum, and it's a very difficult thing to suction because of the consistency. It's almost too viscous, and that keeps blocking the suction probe. And when you've got matted hair as well, like you've got here, it makes it even harder to vacuum. You can see there I was trying to just shake the suction tube to unblock it. We don't want to put any drops in here if all possible. It is already wet anyway, but because it's infected, we don't want to aggravate any existing infection. So we're just going to be patient now. I'm just coming a bit out. I'm on the back part of the ear canal. I can see these flock of hairs. I'm just trying to lift that away from the canal wall, and then I will go back in with the forceps to kind of extract these. Because they're a bit close to the canal, I want to just make a bit of space. Now, if the patient was under local anaesthetic or under general anaesthetic, then we could be a bit more gung-ho in the approach, really, because they're not going to feel anything. But although you may traumatise the ear afterwards, which we obviously want to avoid, but you're not going to cause any immediate pain for the patient. But the patient is awake, and the ear is infected, so it is a bit tender for them already. So you can see all these hairs. I'm just trying to clear some of the discharge off it so I can get a better visual of it. And you can see these hairs now, they're going all the way to the eardrum. So these are all loose hairs. And I have stressed the importance to the patient just to put a bit of cotton on. If you get in the habit, it's all a habit really. So when they do trim their ear hairs, it doesn't fly into the ear. Now, when you have an infection like this, it can sometimes be it can release a bit of a foul odour. And especially when it's wet as well, so the patient on top had been getting water in, so it's kind of all the wrong things in the ear really, and it's all combining. Now they have got a history, as I said, of otitis externa, but it's been exacerbated by the water in the hair. So I'm just gliding the top jaw just below the roof of the ear canal, just trying to get some grip and trying to release some of these hairs. So the remaining of this video is going to be quite a tedious one because I want to see this patient's eardrum. Although even at this stage they were able to hear a lot better, but I'm not able to visualise the eardrum. I don't know what's going on. Is this discharge coming from a perforation that may be on the eardrum? Do they have a cholesteatoma, so it's weeping at the roof of the ear canal? I really don't know, so I want to just remove as much of this as possible, but we know we're approaching the eardrum. We've got to be careful because I don't know how thick this layer of gunk is, and if I just pod and probe too much, we could get through this and injure and traumatize the eardrum. So we're just going to be careful. We're just take layer by layer out. So of course, post-procedure, we've just reinforced the importance of avoiding water in the ear and just to block the ear, but obviously we're into the doctor as well, just to get some antibiotics prescribed for this infection. You can see as I'm suctioning some of this discharge away, the hairs are becoming more visible, which then helps me not only judge whether or not we are right up against the eardrum, but it also enables me to visualize where I need to use the forceps to pincer this hairs out. You can see it's really pushed up against the eardrum, these hairs. And when these hairs do get wet and become matted, it's one of the hardest things to remove. It's really, really complex. You can see, you can tell that the ear is infected because when I put the endoscope in there, now I've not got any suction here. So when you've got an ear infection, the temperature of the ear is raised, and that can cause a bit of condensation, which settles on the lens of the endoscope. Now, when you've got a suction probe in the ear at the same time, that condensation evaporates. But at the moment, we're not using any suction. I'm just using the forceps, so there's nothing to kind of. Now, if I just kept the endoscope in there for about a minute or so, or less than that, probably about 10 or 20 seconds, it will automatically demist itself. But you can see when I put the sucker in, all the condensation, it evaporates instantly. It's been suctioned up almost. Now you can see there's a bit of redness there. Now I know that's the eardrum, so we've kind of almost at the correct depth now, but I want to get all this gunk off the eardrum. You can see it's really matted. Now the eardrum is tender, it's red, so that is also infected. It's got a otitis externa of the eardrum as well. So you can probably visualize probably half the eardrum so far. Now the danger area of the ear is what we call the posterior superior quadrant, also known as the attic. So in the case of the right ear, we're referring to northwest, and if you're looking in the left, it's northeast, and that region of the eardrum is susceptible to a cholesteatoma. So if the eardrum gets sucked in in those regions that I've just described on the eardrum, and it gets sucked in due to the most common cause is a blocked eustachian tube. So a eustachian tube is a narrow tube that connects the middle ear, so the cavity behind the eardrum, to the back of the nose, and its function is twofold. It's a drain pipe, so it allows any fluid that's secreted behind the eardrum to drain out of the middle ear, because we don't want any water or fluid there. We want the middle ear to be full of air. We want the air pressure behind the eardrum to be equal to the air pressure in the atmosphere, and it's the job of the eustachian tube to equalize and regulate the air pressure. But if the eustachian tube becomes blocked, and it normally comes blocked at the back of the nose, there's a shortage of air. There's a vacuum created behind the eardrum in the middle ear because there's no air there. Air can't travel up the eustachian tube into the middle ear cavity, so it creates a suction effect, a vacuum. So the eardrum gets pulled in, and it's normally those regions that I've explained. So in the case of the right ear, the top left region, we call that, as I said, the posterior superior quadrant. That part of the eardrum is a lot thinner and more flaccid than the remainder of the eardrum, and it gets sucked inwards. And then when that eardrum gets sucked in at the top, it creates a little pocket, almost like a little groove, a little cave, and skin that dies off the eardrum and off the ear canal. As it dies and sheds, it should move out the ear naturally towards the entrance. But if you've got this little pocket, the skin can get trapped in the pocket, and this skin then gets it forms a plug, and that plug gets infected, and then we call that cholesteatoma. And a cholesteatoma can be life-threatening because it can get bigger and bigger, and it can grow inwards into the middle ear. It can go upwards towards the brain. So in the worst case scenario, it can cause a brain abscess, a meningitis. It can lead to death. And it can also, of course, it can damage the facial nerve, which runs via the middle ear. It can decay and it can erode all the middle ear structures, so the ossicles, the bones, the hammer malleus, what we call the malleus, the incus, also known as the anvil or the stirrup, which we call the stapes. It can erode these, it can cause a hearing loss. It can just be very, very nasty. Now, when you've got a discharging ear like this, you just want to make sure this discharge is not coming from that. It's not a clesiotoma that's causing it, essentially. And kind of, I know the patient's history, they have got, as I said, they suffer from otitis externa, so this discharge is caused by bacteria in the growing in the ear canal itself, as opposed to a clesiotoma, but I'd rather be safe than sorry. So I just want to clear as much out as possible, just so we know it's not a clesiotoma. And also, because the patient will require some antibiotic spray or drops, most of these antibiotic sprays and drops that are prescribed are what we call ototoxic. So if they do enter the middle ear via a hole in the eardrum, they can cause permanent deafness. So again, we just want to make sure there's no hole hiding away anywhere, so when they are prescribed the medication, they're fine. So we've cleared most of the ear now, as much as we can. We're not going to get every little last speck out, it's just not possible. Whereas we'll be there for hours and we'll end up causing trauma to the ear and further trauma to the ear, because obviously the ear is already traumatized with the infection. See, the eardrum is quite inflamed because that's also infected with the otitis externa. So again, I'm just trying to glide the jaw up against the ear canal without making solid contact, so I can pull some hairs out. These are quite tricky to remove, these last few. They're quite wet, they're up against the eardrum, against the canal, but again, the patient could hear significantly better already, so I'm very pleased. Problems with these hairs, they're so small, the strands. The jaws I'm using, these are the smallest jaws, these are micro forceps, so the jaws of teeth are really, really close together and small as possible, but they can just glide through. So I've just gone back in with the suction just to see if I can suction up some of these loose hairs, but compared to where we started and where we were, I'm much, much happier. Well, I hope you enjoyed that video, guys. Keep well, take care, and be nice and be kind to each other. Thank you, bye.